Any discolored tooth needs a periapical radiograph. Really, really important, because you are looking for undiagnosed periapical lesions. And most dentists don't know if there is an undiagnosed periapical lesion and you put whitening gel into, so you take oxygen and you shove it into an anaerobic area, you are going to have massive sensitivity.
Because I think a lot of dentists are afraid of doing that because they're afraid of not being able to adequately bleach the cervical area.
So here's another point. You can't adequately bleach the cervical area. It's never going to be the same shade, as that's a myth. The last 2 millimeters of the bleaching tray, so that actually tray is not rubbing on the cervical area, and they found it improved sensitivity and made no difference to the whitening effect whatsoever. So you can do that.
Protrusive, this just might be the most actionable and impactful piece of content you'll ever consume on the topic of teeth whitening sensitivity to really help our patients to whiten better without having the horrible side effect of teeth sensitivity. I don't know about you, but for some patients it can be so bad that after about 3 days they don't whiten ever again, and you have to have that awkward conversation with the patient. But now, following Dr. Linda Greenwald's protocols, we can eliminate teeth sensitivity. Like, we could have spoken for like hours and hours and hours, but what we did bring together in this episode is like the top things. Think of the Pareto principle. I'm a big fan of the Pareto principle. This principle suggests that 80% of your benefits or your rewards or effect happens from 20% of the contributions or inputs. So for example, 80% of your sensitivity reduction will happen from the 20% of the little tweaks and the changes you make in your whitening protocols. Let's focus on those 20% of the protocols that are going to make an 80% reduction in your sensitivity, and for some patients, 100% reduction. Hello, Protrusive, I'm Jazz Galanti, and welcome back to your favorite dental podcast. Because there are so many actionable gems and protocols and so much goodness in this episode, we've created a famous protrusive infographic. If you'd like to download this infographic for free, head over to protrusive.app. If you're already part of our community, you will see this infographic everywhere where we post this episode. But if you haven't joined yet, what are you waiting for? It is the community of the nicest and geekiest dentists in the world. So the platform is called Protrusive Guidance, and the easiest way to make a free account is www.protrusive.app. And once you've made an account, you can download it on iOS or Android. When you click on this episode, you'll be able to download the infographic. You can laminate it, you can do what you want, but all the goodness is there, because sometimes, like me, if you listen to podcasts when you're driving, to actually action on some things, to actually have like an aid memoir, a good revision source, we already have the premium notes, which are also downloadable for paid members, as well as claiming the CE credit or the CPD hours. But as part of the gift from this episode, the pearl from this episode, you can freely download our infographic. Now, I appreciate it may sound a little bit attractive to you now, but wait till you get to the end of this episode. You will definitely want this infographic. So don't forget, protrusive.app. I'll see you on Protrusive Guidance. I'm not going to waste a second more. You're going to absolutely love Linda. As always, let's check it out. Dr. Linda Greenwald, welcome back again to the Protrusive podcast. You are such a welcome guest, because we've done a few episodes about, whitening under 18s and icon resin filtration. Everyone loved those. And they love it because I love your direct nature in teaching. I really love direct educators. You tell it how it is. And so I'm especially interested in today's conversation about sensitivity. But for those few people who, for some silly reason, they have not enjoyed that episode just yet, and it's like a gem waiting to be uncovered for them now, please tell us, because they haven't heard about you, tell us about yourself.
So my name is Linda Greenwall. I'm a prosthodontist, specialist in restorative dentistry. This is my year 40 in practice. And I'm still inspired. I still love it every day.
Say that again. How many years in practice?
It is now 40 years.
40.
1984, school of
Amazing.
University in South Africa. Yeah, 1984 we had a special reunion this year because I said to my colleagues in my class, hey guys, we really need to commemorate this. And the one guy said to me, Linda, I hated everyone in my class then. I still hate them now. I said, forget about that. We need to commemorate. And we got our professors, and they came in. And the first thing I wanted to say to our professors, I wanted to say thank you and show gratitude, because the way they taught us in the 80s was very, very tough. There was no mincing words. And I wanted to say thank you because our training was excellent and it was tough. And we have all learned from that. So I just wanted to show gratitude, because there are always people, Jazz, who bring us up with them through mentoring and helping. And even though they may be our biggest critics, we learn from them. So we have to pay gratitude to say thank you. Each challenge, this is my new thing, each challenge becomes your opportunity. Every single challenge, and you grow through that. So we say, why do we have these challenges? Let's call it in dentistry. It's to help you reach your growth point to your next level. And that's why it's coming. It's not because you're a bad dentist or anything else. It's your challenge to grow. And that's when you learn that takes you to the next level of all that we do.
Amazing.
Gives you a bit of wisdom.
And now, of course, you do all sorts. You're in practice. You do so much teaching. I love the webinars that you do. And so, everyone, I encourage to follow Linda on Instagram, all her social channels. They're very, very active in the academy and whatnot. So I'm a big fan of yours.
It was 13 years ago that I decided it was time to give back to dentistry. And that's when I set up the charity. My husband told me I was mad, but I said, I'm doing it anyway. And it's brought a lot of joy, really, and again, on gratitude. But we currently look after 60,000 kids globally, and we do 23,000 children in Luton, helping them with toothbrushing, screening, varnish application, working with refugees, providing free dental care in our practice. In South Africa, we run 12 soup kitchens daily. We've served over 500,000 meals since COVID, and we have 16 toothbrush mamas who help us. And each toothbrush mama helps to look after at least 2,000 kids a month, going to do toothbrushing in schools, but also in their communities. So that is kind of how I balance with some of my high-end, very, very specific, difficult, anxious, kind of stressed patients with their phones out to check the levels of their bonding at all angles and their selfies, to going into outreach in the less in deprived areas where you can give of yourself and your soul to help others with gratitude. Nobody needs to say thank you to you. You go to give of yourself, and it puts your whole life into a perspective. So it's a big difference in balancing.
I love that. And you're quite right to mention the contrast. In my faith in Sikhism, there's something called seva. We call that selfless service. And what you described there was exactly that. So hats off to you. And I'd love to support more of what you do. So we'll put any links that are relevant so we can continue to help you support. And so we'll definitely put that on. Today's topic is a very pertinent one, very global one. No matter where you are in the world, you're likely utilizing, hopefully, teeth whitening as one of the most brilliant, minimally invasive ways to help someone smile. We accept that is the most minimally invasive way that can have a huge difference to someone's smile and confidence. In particular, we talk about young people with all sorts of enamel mottling and brown spots, and we also did an episode on Icon, so we're well versed with the benefits. But one of the drawbacks of the benefits, or one of the side effects, is teeth sensitivity. But we all warn our patients about sensitivity. I've got so many questions. There's so many things I want to draw out from you, from protocols to different things to try to avoid and case selection. But can we just start off with the very basics? Why does teeth sensitivity exist as a result of using peroxide gels?
Actually, before we even start that question, Jazz, I'm just going to go back a few steps.
Please.
Because the first thing is that 70% of patients walk around with sensitive teeth. And we as dentists don't have any protocols to assist those patients who live with their sensitivity. And so before we even start on whitening, we give everybody listening today a things to do list. So while you're listening to the podcast, take a sheet of paper. On one side, we're going to talk clinically. On the other side, we're going to talk what to do now and what are your next moves so that you can make this a habit. So your first thing is to set up a patient desensitizing a protocol for sensitivity in your practice. And you ask every single patient, if you say to them, do you have any sensitivity? They go, no. Then you say, but you ask the 4 questions. You know about the 4 questions.
No, please tell me.
4 questions, really, really important. The first thing is, number 1, do you have sensitivity to cold? Because that means they have gingival recession and all kinds of other things. So that's the first question. Second question is, do you have sensitivity to heat? As you know, the heat question is about pulpitis, because there's a big difference between pulpitis and sensitivity. The patient may not know that. The third question is, do you have sensitivity to sweet? Because that means there's caries somewhere and we need to look at that. And the fourth question is, do you have sensitivity to cold and pain on biting? Because the pain on biting means that there's a fracture somewhere. And then you may say to me, well, is that important relating to whitening? And absolutely. First of all, if you've diagnosed that they have a cracked tooth, you need to treat the cracked, let's call it a cracked tooth syndrome. You need to treat the cracked tooth syndrome, whatever you're going to do, whether it's replacing the old restoration with a composite, putting on a provisional crown, but you need to manage that immediately. So that is protocol number 1. Protocol number 2, does it matter about heat sensitivity? Absolutely, because that pulpitis left untreated, when you will whiten a tooth, will lead to needing a root canal, which needed a root canal anyway, but you've got an unhappy bunny as a patient because you, as the dentist, didn't diagnose and explain to the patient that they need to have a root canal first.
Mm-hmm.
First, so the rule coming backwards is that any discolored tooth needs a periapical radiograph. Really, really important, because you are looking for undiagnosed periapical lesions. And most dentists don't know if there is an undiagnosed periapical lesion and you put whitening gel into, so you take oxygen and you shove it into an anaerobic area, you are going to have massive sensitivity anyway requiring a root canal, which it already needed a root canal. But when you do the RCT on that tooth, it's going to be difficult to control.
And the patient's perception is that, there was a whitening that caused it, whereas an underlying issue all along. You taught me this as a third or fourth year student. You were lecturing the BDA. And so this was like 13, 14 years ago. I remember learning that from you on stage. So I always associate with this you. When I'm thinking about teeth whitening, I always look, okay, any discolored teeth, any teeth that have got large composites, worth doing a sensibility test before we prescribe the whitening, because, hey, this may not be symptomatic, but it could be necrotic, and this could be a flare-up.
Absolutely. And then to try and do a root canal on that, you can't do it in one visit. You might be able to do it in 2, and you often need to do it in 3, which is unusual, but it doesn't settle down. And so the next thing to also look at while we're talking about radiographs relating to whitening is post-ortho. So as you know, it's very trendy now, everyone having then aligning and whitening, or first, before you even do that, aligning or ortho, and then they want to go into whitening. That's another topic. We can discuss a whole thing on that. Mm-hmm. But you need to know what's the nerve status of this. What's the nerve status of the tooth? Because if they're post-ortho, they're going to have flattened roots with a little bit of resorption. And again, the whitening is not going to make it worse, but you need to know, what are you dealing with now? Where are we with what is looking at the nerve? So coming back to the sensitivity question, we've spoken about sensitivity to heat, needing a root canal. We spoke about sensitivity to sweet, because that's sensitivity anyway, it's all lumped together. And the sensitivity to sweet is normally interproximal decay. Mm-hmm. So does that matter? And the answer is not really, because you're going to whiten first, and then you're going to go back and change your restorations with the blended shade of the new composite.
Has that changed at all, Linda? Because I've seen on social media groups where dentists are, and some dentists have this very strong opinion that, so for example, this is what some dentists do, and I disagree with it because I think you're double treating, but essentially they will say, stabilize the caries first, then do the whitening, then go back, insult the pulp again and do the restorations again. And that's why I always follow, especially with anterior work, you bleach, even though you've got caries, okay? And then you treat it with composite. And a few times I felt as though I was being a bit naughty doing this. And I was thinking, is this kosher? Is this halal? Is this allowed, basically? What do you think?
So you just said, Linda says, do the root canal, do the bleaching first, because the research has shown that it shrinks the decay. That's the whole purpose, because it's chemically cleansing the decay. Unless we're talking about a massive lesion, a mega open hole, of course you're going to put a glass on a mirror. You're not going to leave an open cavity, a huge open cavity. I'm talking about small
class 3s, class 2s, that kind of stuff.
That's what I'm talking about when they have sensitivity. You know, the patient may say, when I floss, it's a bit sensitive. Mm-hmm. So that is a plan. It's your strategy plan, right? Mm-hmm. And then coming back to the cold sensitivity, you're managing the gingiva. So coming back to patients in general, because so many patients experience sensitivity and we just ignore it, or maybe give them a soothing toothpaste. What we would do on all new patients and all patients, ask the question, do you have any sensitivity? Don't leave it as no, I don't. You then put an Optrogate in, and you take the 3-in-1 and you spray air onto every single cervical area all the way around the mouth. And you note where they're sensitive on the cervicals. Mm-hmm. Okay, then you're going to note where they have NCCLs.
Yeah, non-carious for the students. Please explain more about what they are for any students listening.
Okay, so an NCCL, very big buzzword, it just rolls off your tongue. NCCL, non-carious cervical lesion. We think that we see much more of it these days than ever before, because of patients' diets and the Diet Coke and the fizzy water and everything else, and their lifestyle of what they drink, everything that they drink. So we see a lot of it. Now, most dentists, I don't know why, and we can discuss the why, but I don't know why they leave it. So you've got like a deep class 5 lesion, and you spray air and they're jumping out the root, out the chair. And it's such a simple restoration to do, but I want to talk about how we would do that. So once we've noted where the sensitivity is, and we've noted it down, becomes part of our charting. And before we even take a scan these days, or we take an impression for bleaching trays, we get those restored. When we restore them, my restoration of choice is a resin-modified glass ionomer. And the reason for that is several reasons. Number one, it retains beautifully. Number two, the resin-modified, the GRC loves the dentine. Number three, you don't get you see of course not your composites, but when you see somebody else's beautiful class 5 composites, number one, they never match. Yeah, and they've got a black line. They're always leaking at the joint. So the GRCs don't leak. You don't get a black line around the joint. You get beautiful shades because of the new coloring, and we would choose a couple of shades lighter. So if the patient has generally a 3.5 teeth, I would choose an A2 shade to work onto all those class 5 lesions. And I want to go through the technique, if it's okay with you, of how
Please. I'm sure everyone's loving this so far, in terms of, because these are daily problems that we see in 70, 90 to 90% of our patients.
And so when you ask me, what procedure do you do? Do you do crowns, bridges, on zirconia, etc.? I sit and I do my GRCs a lot. So let's just go through the protocol. So number one, we use a micro brush, which is not a prophy brush. It's a prophy brush with about a millimeter of bristles, not the whole cup. And we put in pumice with heavy scrub. We make our own, but you can get conceptus. So you put the pumice in heavy scrub and you clean into that class 5 lesion. So we just had a hands-on course at the practice on Friday, and one of the dentist delegates very kindly allowed us to examine her mouth. And actually, we showed the protocol because it's simple and straightforward, and the color looks good. But let's go back.
So, but heavy scrub is like a proprietary branded product, right? Is chlorhexidine containing that one, or
heavy scrub? It's chlorhexidine.
Yes.
Heavy scrub. So you take pumice with heavy scrub. We mix it up ourselves, but the actual product is called conceptus.
Okay. And
then you would polish. There's so much plaque. You see the toothbrush lines in the class 5 lesion, the vertical, the horizontal lines. Pumice and heavy scrub. Then you clean it, wash it off, and take your probe, and you check again, and you'll see there's still, even though you've cleaned it, there's still plaque in the redness of the toothbrush marks. So we go back again, but before we even do that, have a look at what the gingiva is doing around the class 5 lesion, because often the gingiva is growing back into the lesion. So you need to then retract. We would cut a retraction cord 6 millimeters in length, and sometimes we double retract. So we use like a thicker one, the brown one first, then the black one, and we tuck it back so that we just bring it back underneath. So we can actually see the full extent of the lesion, of the class 5 lesion. So pumice and heavy scrub, maybe twice. Then we go to the AquaCare.
I was just going to mention air abrasion, and just like that, you got in there.
Yeah, so you can use air abrasion, you can use your bicarb, you can use your aluminum oxide, any 30 or 50, it doesn't make a difference. But I put in silk, SCYLCK, is got its Novamin, with the same as Sensodyne. So the Novamin, we jet wash it inside the tooth, and again, we use it for all restorative. We jet wash, cleanse it. So now the pumice and heavy scrub is soothing and blocking the tubules. The AquaSeal is blocking the tubules.
AquaSeal is the silk?
AquaCare.
AquaCare, yeah.
Yeah. We then would etch the tooth. And because you're dealing with sclerotic dentine, sometimes you need a double etch. Again, there's so much plaque stuck inside, even though we've done all these cleansing procedures.
Is this standard 37% phosphoric acid etch, or is it the conditioner that often comes with your glass ionomer?
No, I personally go to the etch.
Okay.
And then I use Hurry Seal. And Hurry Seal is a HEMA product, which is for soothing. Or you could actually use Gluma. And I drip that into the teeth, drip, drip, drip. So all the time I've been treating and soothing all the time. Then I go with my GRC, and the GRC I jet into the tooth. There's many different brands. I like one of the brands called Reva from SDI, and it's quite liquid. So I squirt it in. I take a probe and just retract around there, and then I sculpt it with a normal brush dipped in bond, and we sculpt up, vertically up, and contour around the tooth. And then the final bit is the probe, light cure it, and with any excess you remove with a flame.
Mm-hmm.
And then you do the whole quadrant. Don't leave any of them out, because what's going to happen if you leave it? It's just going to get worse. It's just going to be more brushing. So I actively believe being proactive and just sort out, because that blocks the sensitivity. So that's why that's the first stage. We do a lot of proactive before we start.
So the questions I have now is around about these NCCLs, right? The way I'm managing them at the moment is differently for if I'm doing whitening or not. Because I've listened to you before, I've done your webinars before starting teeth whitening, I follow that. Now the protocol is little micro steps. I love it. I'm going to implement some of those because I think they make so much sense to me. And so for those patients about to start whitening, NCCLs to be restored just makes sense to me. In those patients who we're not talking about, we're not having that whitening conversation, they have NCCLs, but they are completely asymptomatic. The kind of conversation I have, the kind of assessment I have in my brain is there are 3 reasons you may wish to restore an NCCL. A, if it's sensitive, then it needs doing, in my opinion. If it's so big that and the first time you see the patient and they're so big, then you think, okay, there's a massive crater here. This needs some sort of protection. Or if it's an aesthetic issue. So I guess what I'm trying to ask is, aside from these scenarios, is it acceptable to just monitor because it's not symptomatic, it's not in the aesthetic zone, and it's small?
So that is one approach. And again, you put it to the patient. It's up to the patient with consent. But I just normally just fill them in. I guess you can monitor them, but we start to see inside the ones that are untreated, the root decay. There's a lot of areas, yes, they're resorbing, and yes, they can, place topical toothpaste or mousses, etc. But nothing really changes in them. So my tendency is just to restore them.
I think you're right in the sense that when we see these patients year by year by year, and then eventually you find, I see patients in their 70s and 80s, and I find that what used to be a very cleansable area of NCCL is now just plaque laden and there's gingival inflammation. And so to promote better cleansability, it totally makes sense. And it's something that's not very invasive. It is proactive, and I like the idea of it.
So that's the option number 1. So you've seen that we're still talking about diagnosing the sensitivity because we have to go right back to basics. Mm-hmm. We've spoken about assessing where the sensitivity is, what is it, what type of sensitivity is. But then if it's, let's call it, the gums are a little bit receded, you can't put a GRC there, and you're modifying the toothbrushing technique, the research shows that brushing with Sensodyne for 2 weeks before you start whitening makes a massive difference. So you can put the patient on to a Sensodyne protocol or any soothing toothpaste protocol, brushing, just that. This was early research from Professor Van Hayward, will stop the sensitivity. So there you have the next way.
And this is just 2 questions back on that. This is just toothbrushing, not necessarily the protocol where you rub it on your finger and you leave it in those areas. This is just regular toothbrushing. Mm-hmm.
Yeah.
And is it a specific type of Sensodyne? Like, for example, I think previously you've talked about repair and protect. I don't know if they still have that terminology anymore. Is there one that works better than the others prior to whitening?
No, I think all of them are absolutely fine. Absolutely fine. And there's newer versions and whatever works for the patient. What I do check, though, is on all toothpaste and soothing toothpaste, and in general, the current toothpaste that are being used, many patients suffer from sloughing of the cheeks, of the mucosa. I don't know if you see this.
Yes.
So you need to, I always ask the patient when I'm doing a general exam, what toothpaste they are using, because some cause more sloughing of the cheeks. And so we say, change your brand. So when it's talking about a sensitive, desensitizing toothpaste, use it for 2 weeks, then go on to the next brand, and then just change it a little bit.
So we want A, the sensitivity sorted, and B, no sloughing. Sloughing do we believe that's the SLS component?
Yeah, we think it's the SNS. Some of them have coverine blue dye in to make the teeth look whiter, but it may be too strong, so you need to just check and monitor with the patients.
Okay, so you've done your diagnosis, you've noted the NCCLs, for those that are amenable to treatment, and which most are based on this conversation, let's use that. You're going to use a Reba, like you said, you're going to follow that fantastic protocol, which we're going to get the video for, and a little checklist, and our team, a lot of people are driving or on a train, they haven't got access, we'll make it a nice little download, and then also link everything to your website as well, which would be great.
And we've got a new WhatsApp group on bleaching, just by the way.
Oh, wonderful. They'd love that. And fantastic.
It's really all that there. You put the cases on.
Brilliant. Now, you've also talked about using Sensodyne for 2 weeks prior to teeth whitening and then just brushing. And if they're having the sloughing, or that brand is not working for them, then maybe change a brand. Would you agree with that? Because I found patients where they tried something, they're already using a sensitive toothpaste, and just by suggesting a change in the chemical formulation, a different brand, then they suddenly come back and their sensitivities, significantly improved. Is that something that you've observed as well?
Yeah. So when it comes to the different Sensodyne brands, there's a lot of different ones. So you can swap between the brands because they've got different functions like that. So that's one option. Then the next thing is to understand why patients get sensitive during whitening. And we would then...
Can I just, before you talk about, because this is such a big part, but one thing I just want to just cross off before we move to the actual mechanics of teeth sensitivity during bleaching is, with your protocol, which sounds wonderful, are we expecting that patients can hopefully say that, you know what, I can have my ice cream again? Because sometimes they say, like, my centrals are super sensitive, but when you look, you don't really see much recession, you don't really see any NCCLs. They just have, generally, they've always had, since I've been 12, I've always had sensitive teeth. Are we going to help that patient as well?
That helps that patient as well. Just recently, I saw a patient who we did this treatment, exactly what I'm talking about, and she had massive erosion on her teeth as well on the occlusal surfaces. So we did a 3-step technique written up a lot by Dr. Francesco Valletti. So we did the NCCLs on the outside. We built it up on the occlusal composite. We opened it a vertical dimension. I hadn't seen her for a year. And she said to me, no, finally, I can eat so many different things. I can eat everything now, whereas before I was so restricted on what I could eat because of the tooth sensitivity, because of the erosion. So
controversial question. Does Linda say that Bruxism and occlusal forces may be a contributor to sensitivity?
Yeah, because of the micro cracks within the tooth. So when we're talking about sensitivity on patients, the first thing we need to understand that within 5 to 10 minutes of placing whitening gel, we are in the nerve of the tooth. And so, because some dentists think, well, they make up whitening as they go along because they've never really learned it and they just think it's very, very cosmetic. But actually, to understand that it goes into the nerve of every tooth, that's why I'm saying, take a radiograph. We need to know, what are we dealing with here? Because the way bleaching works and the way sensitivity works, it's all related to the actual anatomy of that particular tooth. So and the way that the whitening works, it goes into the weakest part of the tooth first. So it will go into those micro cracks on those bruxes. It will grow into the crack where the patient has a cracked tooth syndrome. It will go into a porous tooth, and it will go into the non-vital tooth. It will find the weakest link to travel, which is why we need to know that.
Path of least resistance.
That's how it works. And that's why some patients, I know we spoke about white spots, but some patients who've never had white spots, suddenly when they were doing whitening, they become very alarmed that suddenly there are these white patchy areas on the tooth that were never there according to them.
This freaks them out. This absolutely freaks them out. And then what the patient does, they stop whitening. Whereas I'm hoping you're going to say that actually they should be encouraged to continue, reassure them, and then they'll get a good result. And obviously what you've taught me before, and I'm always echoing anything teeth whitening related, I've always learned from you, which is that is a sign of enamel damage. What that's highlighting is damaged enamel. So
what it's actually highlighting is there's porous parts within the tooth, and the whitening has taken up too quickly. So that particular part of the tooth is actually the enamel anatomy is porous. So you particularly find this with the higher strength whitening gels, which is why we like you to go low strength. So suddenly they're on 16%, everything is suddenly all mottled when they never had mottled teeth. We've seen a lot of patients referred from other dentists because of this problem. And as you say, it's reassurance that they need to continue whitening. They also shouldn't do stop-start whitening where they'll do 2 days and then stop for a week, and then because you want to have slow and low. Still, Jazz, that particular part of the protocol is still the same slow and low concentration as you go along.
Excellent. So we now know the mechanisms. We know that it's the peroxide is reaching the nerve within 10, 15 minutes and will always go the path of least resistance. In terms of predicting who is susceptible, obviously, now that we know this background information about, the 4 questions that we're going to be employing, using restorative materials like Riva Like-Cure, for example, to restore those NCCLs, using desensitizing toothpaste beforehand and finding the right formulation before you even start whitening. So already we're onto a winner. But I found it surprised that some patients, I warn everyone on sensitivity, and some people come back with significant sensitivity that they just can't do it. My wife being included, like within like 2 days, she can't do it anymore. I get a bit, but not too much. Whereas some patients, there's a particular patient I saw a few weeks ago, and bless her, she's so sensitive to everything. Every time I've done a restoration, super sensitive, the bite needs time to settle, go very slow with her, easy with her, warn her of everything. And I double, triple warned her before we started teeth whitening that, okay, I think your teeth will be very, very sensitive. I just have a hunch. She came back and she said, nothing, zero. Okay. And so, and her teeth looked fine. There's no NCCLs and there's no difference to some other patients. Are there any individual characteristic traits that people's baseline level of sensitivity is more than the others?
I think it also depends on tolerance. And I also think it depends on hydration.
Okay.
Hydration is a new area that we're looking at, because a lot of patients who have like a high lip line like me, the lower third of the tooth is darker. And the hydration, it's to do with, if they're not hydrated, the tooth, it's dehydrated. And the whitening dehydrates as well. And so I think that contributes to the sensitivity. So now we also, with our patients, and especially with the little kids with the white spots, we're looking at their hydration levels and we're looking at their dietary levels, because the patients have high lip lines, class 2, sticking out teeth. They're dehydrated, they're not drinking enough water, and the teeth are porous, and so they're accumulating more stain. But we go back to, first of all, water for all patients, because none of us actually drink enough water. So we're looking at the hydration and looking at why they're sensitive. But most of the time, you can't predict. So the research shows up to 80% of patients are going to be sensitive during whitening. And this is particularly with higher strength. We try and predict, and we look at what would cause them to be more sensitive. So some of the protocols would use the whitening gel 15 minutes in the morning, 15 minutes in the evening. And they discovered those protocols were more sensitive.
Oh, wow.
And and so there are a lot of protocols like that. Oh, you just do 15 minutes. Double whitening a day makes it more sensitive. Then it comes back to the tray design. And they think that a rigid tray makes it more sensitive. They did a study and they just put bleaching trays in, and they discovered with no gel that 30% of people were sensitive just with a tray sitting around it.
Wow.
So then the next study they did was they cut off the last 2 millimeters of the bleaching tray. So that actually tray is not rubbing on the cervical area. And they found it improved sensitivity and made no difference to the whitening effect whatsoever. So you can do that. So if they're so sensitive, like you were talking about your wife, cut back 2 millimeters off the bleaching tray on the cervical area. So it's not rubbing.
So you're shy of the gingiva. You're like super gingival 2 millimeters.
You're super gingival 2 millimeters above, or even a millimeter above. And you may find that will improve it.
That's fascinating. Because I think a lot of dentists are afraid of doing that because they're afraid of not being able to adequately bleach the cervical area.
So here's another point. You can't adequately bleach the cervical area. It's never going to be the same shade, as that's a myth. It's never going to. And when patients come to see and they go, look, this is not white enough, we go, well, then just don't bring your teeth down. Maybe you're going to see that. You know, you're not going to. You have to be realistic of what whitening will do and what it's not going to do. On the root area, it's not going to be B1++, ever, with whatever whitening gel you're going to use. So that's an important factor. Again, it's to do with the root anatomy and all that stuff.
The thin enamel in that region, and enamel being so important in the good whitening effect.
It's not going to be the same. So that's really, really important. The other factor is medication that patients take. When you were saying we need to look at medication, we're also talking about Roaccutane at the moment, because Roaccutane, I don't know if you know this, but Roaccutane, because we've got the ortho kids who whitening in the retainers, and Roaccutane, again, it dries out the cheek, it dries out the skin, but some patients have dry mouths, and those little kids often after ortho and Roaccutane, because Roaccutane is a long period of time, the teeth are gray-green.
Mm-hmm.
I was just looking it up last night again, and they think it's due to the dehydration, because the Roaccutane dries out the mouth and the saliva as well, and you get the.
I've never heard of this Roaccutane. Can you tell me what it is? I've never heard of it.
It's called isoretinoin, and it's a medication like a vitamin A. It's called isoretinoin, and there's different versions. The US is Accutane, we call it Roaccutane, but it's kind of standard protocol for the dermatologist to put the kids onto Roaccutane. There's a lot of write-ups. I'll send you some of the press releases about it. But let's call it the Daily Mail, often those kind of papers will cover stories about Roaccutane, because what it does, it causes depression in kids and suicidal thoughts. Mm-hmm. So this is quite an important thing. So coming back to always checking medical history on all our patients. And if the kid is on Roaccutane, you need to tell them, well, you need to discuss with the parents and you need to discuss with the dermatologists. The other new drug, and they give it together or they swap them, is lime cycline. You heard of that one?
Yes, heard of that one. Is that for acne?
Yes, but it's the same. So they're on LYME, lime cycline, because we used to do minocycline, tetracycline, and doxycycline. They're either on that or they're on Roaccutane. And the Roaccutane doses, the way it goes 20 milligrams, 40 milligrams, 60 milligrams, and it goes on for 2 years. So then you have to balance the acne versus the discoloration on the teeth. And again, discussing with parents. Of course, we're not going to say with the child, but the children's welfare is really important. So we are understanding they're on the Roaccutane, how long they've been on it. And not every child gets great teeth when they're on Roaccutane. And then again, you come back to talking about hydration levels. So my next new business marketing idea is to actually print water bottles with our practice name on, to give to the kids and to give to the adults about drinking water, just drinking more water because of hydration effects, discoloration effects, and healing the mouth with water. I will write a paper on this. It just haven't been enough time.
I love it because it's putting the mouth back in the body. It's reminding us that, we are, the theme of the AES, which I like to go to in Chicago for 2026, is the oral physician, and about, the putting us back in the body, putting the mouth back in the body, which is so important. So it's a nice holistic approach and step back approach. On this theme of hydration and dehydration, I've seen before exactly that kind of patient you describe, which had like a two-tone appearance to their teeth, and they're very, very gray. And I have found that on one instance a few years ago, this patient that just did not respond as well to whitening as I wanted. And it makes sense that, okay, it's because of the fact that they have this profile whereby the lower incisal third or half is too dehydrated, I imagine, but it's got this grayish appearance. Is there any hope for this patient with teeth whitening, or are they looking at veneers?
There is hope, and everybody responds. So everybody is different in their response. And sometimes on those patients, because it's dehydrated enamel. So think of it thinner, desiccated, more dentine laid down. So you get that two-tone effect. You need to go for the 6 to 8 week protocol, whitening with low strength. Coming back to the 5%. 5% carmine peroxide, low and slow, but it can change and it can make a big difference on those patients.
Can you name a brand of 5% carbon peroxide?
Yeah, we'll talk about that. But the last patient yesterday, short lip, the 2/3 is dehydrated. Obviously, I spotted it straight away, but we were having a general discussion about that, about her teeth in general and sensitivity in general. And that is a factor. And an interesting thing is that her boyfriend said, you need to fix your teeth. First, fix your teeth, darling. And so we come back to understanding diet sheets, coming back to those old-fashioned diet sheets we was taught. Get the patient to fill out diet sheets, either a week and day, 2 normal days, and have a look. Email it to them and email it back, and just have a look at what they're actually drinking. Because you'll find it's not enough, and that comes back to the discoloration. So when you say the whitening is difficult, check on the whitening gel being water, and it still can dehydrate the enamel during the whitening process. And for those patients who are already dehydrated, the results may take longer. So you keep going and going, and they will get there. But it's slower.
With the dehydration, often when we're doing like a rubber dam on, with dehydration, we see the teeth get whiter. But I think in this instance, it's like a chronic dehydration, which has a grayish effect. Have I got that right?
Yes, a chronic dehydration, and it's grayish because the enamel is so dehydrated, it's picked up some internal stain within the food, etc., that they're eating. So yes, okay. So then I want to talk about putting on a rubber dam and the rate of dehydration on a patient. When you're about to start composite bonding, the first thing you have to do, even almost before the rubber dam is on, is choose your composite shade, because so quickly the teeth dehydrate and you're choosing lighter and lighter composites which don't blend. So coming back to that, the same rate that a tooth dehydrates is the rate that a tooth whitens.
Mm-hmm.
Now, when you put on your rubber dam, just watch the tooth as it's dehydrating, because it doesn't always dehydrate evenly. It will be a little bit patchy in places as it's losing water. That's the same pattern as how the tooth whitening will appear. It's again associated to the path of least resistance.
And this is again where we have to reassure a patient after they've got up and they remove the rubber dam why they got those patches, in the same way with the whitening. You've repeatedly said about using a low and so protocol, which makes a lot of sense. In other countries, they're using ridiculous percentages, 25, 30%. Sometimes, in Singapore, I remember using such percentages actually. And it's good in a way that we use lower percentages here. 5% carbamide peroxide, any proprietary brand that you recommend?
There's not many on the UK market. Basically, the main one is Novon Mild from Optident, Henry Schein, and it's got a special soother inside, which is a toothpaste. Calcium phosphate is the soother inside. So when we're talking about concentration, we can also talk about the difference between carbamide and hydrogen. Mm-hmm. Carbamide has 16%, 10%, and 5%. You should always have 5% available for a certain category of patients. Number one, those who've always, like you're talking about your wife, is being so sensitive to whitening, they need to go on the 5%. Then patients with medically compromised health history, who have got complex medical issues, for them. Then those patients who've tried whitening before, and also you can see, we spoke about bruxes. If you ask a dentist if they've done whitening and if they had sensitivity, they'll all tell you that they have on the low incisors, they're sensitive because we all bruxing, we all stress bunnies, and so we get sensitivity just on those lower incisors, little micro cracks. Mm-hmm. So on all those patients, and patients who've never been able to manage whitening before, it's all with a 5% carbamide peroxide. There is another brand called Cavex. It's from Amsterdam, 5% carbamide peroxide. But we would use that for those patients that are super sensitive. 5% carbamide peroxide is also used for therapeutic aesthetics. I don't know if you've heard of this term.
No.
Okay, I'll send you my publications on this. So we use the bleaching tray as a therapeutic tray, which comes back.
I see what you mean. Okay, yes, carry on. Mm-hmm.
It comes back to all aspects of a patient's oral health. So the bleaching tray becomes this therapeutic tray, and we deliver different chemicals. So tooth mousse, MI paste particularly, is really good for soothing and desensitizing. So on top of our normal protocol, which we've gone through before on home whitening, and that they just do the upper and then they do the lower. And just by the way, the reason for that protocol is because the upper teeth are not as sensitive. So we always go to the positive, upper whitening first. But because of that, we would always give our patients a brand of proprietary soother. There's quite a few different ones, but I'll just tell them to you. The main one is it's either tooth mousse or MI paste, because it's got ACP inside. And ACP is a tubular blocker, and it also works on the enamel to smooth the enamel and the defects in the enamel. So that is great.
And also good for ortho demineralization, early white spots. It can be quite curative without teeth whitening, right?
Yeah, decal's really, really good for that. Yes, you can use the Durafat toothpaste as well. But to put in the bleaching tray, we can use tooth mousse, MI paste, and there's a new one, which is MI paste plus.
That's the one with fluoride?
Yeah. The tooth mousse doesn't have fluoride. Mm-hmm. But the MI paste does have fluoride, different concentrations. Then the proprietary one, there's one called Relief Gel, and that's from Philips, Night White Relief Gel. And Philips brand has got ACP, potassium nitrate, and fluoride inside. And you run a line into your bleaching tray, and the patient would wear that an hour a day, an hour before whitening, an hour instead of whitening, or an hour after whitening, and that should solve your issues with sensitivity.
And that's a top tip right there, I think. I mean, to use it as which I do, and I was going to ask you about that in terms of what you recommend to put inside it. How about those in the past, what I've done, not related to teeth whitening actually, but high caries risk patients with root caries prone patients, patients who've had, let's say, radiotherapy and their saliva is going to be low and poor quality. I often give them like a very passively fitting Essex retainer. And then I encourage them to use certain agents like tooth mousse. I show them on Amazon which one to get. Do we have sufficient evidence base for that, or is that something that you're a fan of?
Yes, we do have evidence. It's not just a random thing. There is a lot of evidence on that, and Professor Van Hayward has published a lot on this. Then the other study that was done by a guy called Lazarchik, 2010, was for special needs patients. So you use it, but you use also for those special needs patients, the carmine peroxide in the low concentration. So those patients with the poor high caries rate patients, they did a study, and the guy's name is Yao, 2013, where they looked at the difference between chlorhexidine and carmine peroxide, and they found that carmine peroxide was more bactericidal to help the gingiva than actually chlorhex. So on another WhatsApp group that I'm on, a digital group, they were showing a case where the patient, they did new crowns, the gums were all swollen afterwards, they redid the crowns, the gums were still upper 3-3, gums were still swollen. So I said to them, put in a bleaching tray with carmine peroxide 5% inside and just heal the gingiva. Then go back to taking all those crowns, putting provisionals, keep with the carmine peroxide to get everything balanced. Make sure you don't invade the biological width before you go to be able to do that. But this is quite a top tip in terms of that. Your elderly patients who have poor oral hygiene, on the label, there's a little controversy because on the label it says only for tooth whitening purposes, 5%, or all of them say for tooth whitening purposes. But we use it for healing because it's been used for healing for 70 years. Mm-hmm. This was a whole discussion. That's how the whitening was invented, because the orthodontist noticed the gingiva was swollen. So that was why we would do that. But 5% in the tray, one night 5% upper, one night 5% lower, one night tooth mousse. So the other soothers which we didn't mention, there's Protrusive. Protrusive is from SDI, and that contains potassium nitrate and fluoride. And then you also have opalescence. It's called Ultra Ease. It's from Utah Products. Again, it's another Henry Schein Octident product. That one is just a syringe of potassium nitrate. So the way that potassium nitrate works for sensitivity, it stops the polarization of the nerve. So it stops the nerve continuing to fire. It cuts it with the potassium nitrate and just kind of temporarily, doesn't paralyze it, but stops it. So the nerve is not firing. So that's why we use fluoride for blocking the tubules. We use potassium nitrate stopping the repolarization of the nerve. We use ACP for blocking the tubules. And another product which you use, which we mentioned when we're doing the NCCLs, is the Hurry-Seal or the Gluma. So the Gluma is just a liquid, or the Hurry-Seal is a liquid. And again, you're blocking the tubules. You can use it as an intermediate dentine seal as well. If you're finding that a lot of your composites, not you personally, you really know what I mean, but one's composites, you do your normal protocol and patient has post-opera sensitivity, which we all hate, because sometimes we need to remove the composite because it's pulling in, all those stories. Actually redo it. You do your etching, you put the Hurry-Seal in, and that stops it. That was a colleague of mine, Dr. Mervyn Drew, told me about that. So the Hurry-Seal is very useful for all those sensitive patients, for all those ones, and again for restorative reduction after post-op restorative.
I think you taught me as well, because I believe your son's doing wonderful work with AI actually, and notes and stuff, and I've been in this space as well. And often, I don't know if you've actually counted how many words are spoken in a 1 hour consultation. It's like 10,000 plus. It's actually crazy. And I feel with the pace that me and you both speak at, we've probably hit 20,000. And I know that dentists have got incredible value from you. One personal takeaway now, I mean, all the protocols said brilliant. Some things were great revision for me, but what a wonderful reminder you gave us, right? That the cervical region just won't ever whiten as well as the others. And so I think we forget that. And when we talk to patients and we take that photo with the shade tab, we say it's going to go this white, just pause and say that, oh, but not this part. It's like, imagine you're in Lion King, okay? You can go there, but you can't go there. Like, think of Lion King next time you're whitening your patients. And I think it's a great reminder. And I look forward to adding more resources from you in the show notes. I know you're involved with so much. You've got some amazing events coming up. I'd love for people to come and learn more from you, because every time I speak with you, I learn so much. Every time people meet you, your energy is brilliant. How can we get more of this energy? Where are you next speaking at?
So our next gig is an important conference. It's called Future Dentistry. It's on the 1st of November at the BDA, and we would like more dentists to attend. We have an amazing lineup. First of all, talking about dental AI and how we can implement it into our practice from all different aspects. We're talking about the future of contemporary restorative zirconia crowns, inlays and onlays, and the zirconia veneers. We're talking about early intervention orthodontics, because, there's this whole thing, everybody waits to the right time. But Professor Peter Mossy will be talking about how you really properly early intervene and what you need to do. We're talking about the latest techniques in implants, what is new, what's the future, how we're going to go with this, digital dentistry, how we integrate it, the different scanners and all the different techniques. The dental technicians will be talking from their angle. We also have to have a medical legal update, a safeguarding update, so you are fully up to
the core CPD is ticked off as well then?
All your CPD, all your core subjects, it's all ticked off. But the benefit of this is that by attending the conference, you actually are contributing to the charity, to the work of the charity, to help more patients attain dental wellness, which is really important.
Well, I'm definitely going to put the link, but for those who are maybe driving around, check the show notes. But is it the BDA website? Is that where they book?
They book through Eventbrite, and I'll send you the link. It's 1st of November, BDA, Friday
Amazing.
the 1st of November.
Perfect. And those topics that you covered are very sought after topics that Protrusive ask about, especially the interceptive orthodontics. AI is such a big thing. I'm a big fan of it, and I encourage everyone to explore these avenues. I think people are sometimes shy, or they're like, I've been doing it for 10 years. I don't have a problem. When they learn to embrace AI, they suddenly gain 4 or 5 hours a week that they never knew they could possibly have. And it reduces your stress, improves your quality of your notes. So it's amazing you're talking about that. And also, yes, zirconia partial coverage restoration, something I've talked about, not talked about, but asked about on the podcast. So it'd be interesting to hear an update on that. So I'll definitely put the link in the show notes. Some fantastic topics. Linda, I'll put all your show note, all the sort of follow links and all your wonderful things that you do. Thank you so much from the Protrusive community for all you do, the charity work, the education. I can't believe you've been in this game for 40 years plus. That's amazing. Please, can we have another 40 years? Because we don't retire anytime soon.
So nice to talk to you. It's lovely to talk dentistry with you. You're very inspiring. You do amazing work. And thank you for all you do on your education and all you do to inspire so many dentists. Your impact is huge all over the time. Whenever I go to dental meeting there, I heard you from the Jazz podcast. It's all up to you, Jazzy, and all the protrusive things and all the wonderful things you do. Thank you so much.
Thank you. Thank you so much. There we have it, guys. Thank you so much for listening all the way to the end. Don't you just love Linda's direct nature? She is brilliant. Please go and support her, learn from her and her colleagues on the 1st of November. And if you want any of the resources, some of them will be available on YouTube or wherever you're watching this, and the rest are on the Protrusive Guidance. Don't forget to get that infographic only on Protrusive Guidance. I want to thank my team as always, Erica, Marie, Jan, Chriselle, Julia, Nav, Emma. Our team has been growing throughout the years, as have you guys. The subscriptions on YouTube and everything, they mean a lot. But if you really want to support Protrusive and get the most out of it, we'd love to see you on the app. I'll also put any papers, any links that Linda suggested, including the Eventbrite link for her event on the 1st of November. And if you found this episode useful, please share it with a colleague. This is how the podcast grows. This is how we're able to attract wonderful guests like Linda to help make dentistry tangible, which is the ultimate mission of this podcast. For those on a paid plan on Protrusive Guidance, scroll down, answer a question on the quiz. Marie, our CPD queen, will email you a certificate. And yes, we are PACE approved, so if you're in the US, you're going to love it too. Thank you so much again for listening to the end. I'll catch you same time, same place next week. Bye for now.